This is a group endeavor, and a lot of the group is up here. One of the group, Dr. Forster, is here. I just got a text from another one, Mark Luciano, who's in India right now, telling me that I needed to redo this for neurosurgeons, but we'll see how it goes. What we're really talking about here is something similar to what we've been talking about this morning, and that is, how do you decide whether two people with very similar anatomical deformations have very different outcomes? And I would like to acknowledge funding from Conquer Chiari. And usually I talk about how this is different from this. This time, both of them look like this, where there's lots of tonsillar dissension and lots of crowding, and yet some people seem impervious to that and don't become symptomatic, and others do. So we're going to take an attempt today to figure out why that might be. Now, whether you use 3 or 5, somewhere around 5 millimeters of tonsillar dissension, and depending on who you look at, it's 1 to 2% of adults, and we're dealing with all adults today and all females because the vast preponderance of adult diagnoses are females. It may be up as high as 3%. In fact, the Smith et al. Paper found pediatric cases around 4%. In that sample where they took a subsample from about 70,000 MRIs. But what we're really getting at is why instead of 1%, say, of adults, why only 1 out of 10 of them become symptomatic. Now, one possibility is that there are not only differences in anatomical deformation. In fact, in these two groups, there appear not to necessarily be anatomical differences, but there may be differences in environmental stressors. There may be differences in the HPA axis response to environmental stressors. And thirdly, there may be differences in biological resilience, in particular in terms of estrogen and estradiol. So that's what we want to look at today. We tested 62 adult female Chiari patients, 43 which were decompressed, and the decompression had occurred more than 1 year before this study, and 19 that were non-decompressed. And this is a fairly small sample size, but this protocol was difficult. So we literally had 2 days of 6 salivary cortisol assays a day for a total of 12. They finished that. We had very detailed instructions. They received a big package with 12 of these in them. They were all color-coded to try to optimize when they completed the assays. We even standardized everyone to the same point in their menstrual cycle, because these were all females and we're dealing with estrogen. This was probably the most difficult study I have ever done in Chiari, because logistically it was a nightmare, because everyone had to be started at the same time. And so 62, when you think of all that, is not such a small sample size. And we not only looked at cortisol, we looked at interleukin-6 and C-reactive protein, as well as estrogen and estradiol. And a large battery of clinical assessments, in particular the UCLA Loneliness Scale, the McGill Pain Questionnaire, Impact of Event Scale, which has 3 subscales on trauma, and the Oswestry Head and Neck Disability Scale, and a bunch of others. So, we're going to present some evidence that suggests that UCLA loneliness scores correlate with a whole bunch of other symptoms. Now, who cares about loneliness? It looks like it's a marker for social isolation. And there has been a whole lot of evidence lately, not only that it has an effect on psychological assessments, but also even epigenetic effects on upregulating pro-inflammatory gene sites. So there is some good evidence for why we would want to look at loneliness. And we'll go over that in a little bit. Cortisol levels in Chiari patients are positively correlated with rumination scores. And the last two, I think, are the most interesting results. Using analysis of variance, there's a surgery status by loneliness level interaction when you use estrogen levels as a dependent variable. And finally, when you move on and look at just the decompressed sample, and these people are thought to have more severe symptoms, in fact, loneliness mediates the relationship between estrogen level and two different measures of trauma from the impact of event scale. So, why did that happen? Okay. This is really a variation of McEwen, his concept of allostatic load, except it's a balanced system between really the combination of the effect of the environment, the effect of the HPA axis on the arousal level, and the effect of biological resilience. And what we're saying is that it is likely that the people that become symptomatic do not have a balanced system. Something becomes out of kilter, and then you have a cascade that results in symptomatic Chiari. On the other hand, people that are asymptomatic can either compensate for increased environmental stressors by a less reactive HPA axis arousal system or a stronger biological resilience system. Now, there is a lot of evidence supporting McEwen's model on allostatic load. It started off where he looked at just socioeconomic status, and he found out that, in fact, it did not predict how bad off people that were lower on SES were. And this was his 1998 New England Journal of Medicine paper. So he has spent since 1998 working on this in large part on this allostatic load idea. What we want to emphasize here, though, is that it's not just the HPA axis side, but it's also that balanced system between the arousal side and the modulation side of resilience, and that you need ways of measuring that to assess this full system. And I'm not going to go, I apologize for the small print here, I'm not going to go into too much detail here, except to say that the hypothalamic pituitary adrenal axis is a well-respected measure of distress, and that after 15 or 20 minutes, you start seeing a cortisol spike after that system has been activated. There are some advantages. We included C-reactive protein because it's so cheap, by the way. No one really cares that much about C-reactive protein, but interleukin-6 probably is a better inflammatory cytokine to include. So we have cortisol and IL-6 as well as C-reactive protein. Now, this HPA axis dysregulation is known to occur with PTSD, and there are many similarities between PTSD and the symptoms of chronic Chiari patients. But the main difference between the two is one is acute, the trauma, and the other is chronic. But in fact, it looks like there are very similar effects on this HPA axis and resilience. So that's why we use that as a model. So we have discussed HPA axis and allostatic load models of distress and how humans deal with it. Now we're going to link this to a CM1, to Chiari malformation type 1, where we have symptomatic people. Now, there is for example, substantial evidence for increased levels of depression and particularly anxiety and stress in more recent studies that are presently under review, such as Garcia et al. 2018, that are consistent with allostatic overload. And a group of us from the same group had a paper that came out this year finding that non-decompressed patients showed evidence of expectancy effects that were consistent with an allostatic load thing. Although one person in this room remains skeptical of that. But we'll see if it's replicated. That was supposed to be a joke. Yeah, didn't work so well. Now, here's our problem though. First of all, when applying it with Chiari, we can't simply say that the pain starts a cascade that results in this unbalanced system, because something can't cause itself. That would be an infinite regress. So it can't just be a pain model. Furthermore, it also can't be symptomatic versus asymptomatic in terms of anatomic deformations, because they have almost identical ones, and some people become symptomatic and some do not. So there seem to be, as we've already hinted at so far, two reasonable candidates for this. And I would argue that another one exists too. So first of all, the assumption on this model is it is a necessary but not sufficient situation to have anatomic deformation. Now, some people talk about Chiari 0, but that is very rare and we're not sure what it is. So what we think is it is a necessary but not sufficient situation to have the tonsillar herniation, but that you need an environmental stressor on top of that. In addition to that, it must be an environmental stressor that either has an overreaction from the HPA axis sympathetic nervous system or an underreaction from the biological resilience side on the estrogen and free estradiol. And this is essentially borrowing from Monroe and Harkness's 2005 paper on depression, their kindling effect, where you basically have to have some environmental effect that precipitates this cascade. And again, it could be due to a very powerful environmental stressor. It could be due to an overreaction from that on the arousal side, or an underreaction from the resilience side. And estrogen, we know, is both neuroprotective in terms of attenuating the effect of free radicals, and also in dealing with ischemia. Where things get a little more complicated is what happens with estrogen after menopause. And so it may not always be neuroprotective, in other words. So one possibility is that it needs to be at acute level. So you don't want a high baseline level of estrogen. When you have a response to a stressor, you would like it to be at a low level and then have an acute increase in the level of estrogen. And I don't want to mess up the outcome, the surprise, that probably isn't that much of a surprise, but yes, the data very much support that. So that is estrogen. We are predicting that it's neuroprotective and it's a balanced system to help shield individuals from the HPA axis arousal. And Cacioppo and Cole et al. Have a whole bundle of studies on the importance of loneliness, our environmental stressor variable, on how it has not only psychological effects, but biological effects that can be measured and replicated over and over again. So once again, we want to test what we're going to call a dynamic interplay model. It's a dynamic interplay between the HPA axis arousal and the biological resilience in our response to environmental stressors. So, if HPA axis effects are indexed by biological effects, such as loneliness, if they induce symptomatic CM1, but are modulated by neuroprotective estrogen levels, then it is reasonable to assume that there should be a loneliness level by surgical status interaction. And that is a simplifying assumption that we did in this study. We are assuming that non-decompressed people have less severe symptoms than decompressed people. That is not always the case, but that was a simplifying assumption to make this first study possible. As we said before, we tested 62 people, 43 decompressed, 19 non-decompressed, and the way these biomarker studies tend to go is that it doesn't work out perfectly. That is, someone will miss every once in a while a few of the 12 cortisol data points, or, and in our case, the worst one was interleukin 6. It turns out that you have to pack it in ice. So we use Quest Diagnostics to collect these assays, and they were not packing the IL-6 in ice. So we have a smaller sample size for interleukin 6, and that's why, because some people at Quest didn't realize that you had to pack it in ice. So we had cortisol, serum-based assays, as well as the clinical surveys that people completed. Now, I'm not going to go into the full cortisol stuff as much today because there are different ways of testing it. The awakening response versus the area under the curve. And we really, in the more complete version of this, will emphasize the area under the curve, although the awakening response for cortisol looks similar to the area under the curve measure. Well, I did it again. This is the correlation matrix, and I want to emphasize this loneliness. It wouldn't fit when I put the whole name on. Anything here over 0.25 is statistically significant. Now notice that the one with age wasn't statistically significant. And I should note at this point that that's probably a good thing, because you could say, well, what if your non-decompressed group wasn't as old as your decompressed group? And incidentally, the mean age was 36 for decompressed and 34 for non-decompressed, and that was not statistically significant. One concern when you're comparing estrogen is that the older group may have had lower estrogen levels, and that could have caused this in a way that would not have meant anything interesting. That was not the case. So this is not due to these two groups having different estrogen levels due to one group being older than the other. So that's the key finding from this thing. The key finding from this is a more truncated correlation matrix. And here we see the estrogen when I first looked at this table, I'm thinking, wow, we just spent 2 years collecting all these data, and we have nothing. So that 0.22 negative correlation, where estrogen went down as loneliness went up, that is not quite statistically significant, and we're thinking, well, we didn't find anything in this. The world is frequently more complicated than it looks at first because you need to look at it separately by surgical status. And this is actually the summary table from analysis of variance for that analysis in which estrogen is the dependent variable and surgical status and isolation here is loneliness. So we have high and low for isolation or UCLA loneliness. Surgical status is 1 decompressed, 0 non-decompressed. And notice that we have a quite substantial interaction between these two. And here's the key part. For means of estrogen, for the non-decompressed group, we have a much lower level of estrogen at low levels of isolation compared to high levels of isolation. On the other hand, it goes in the reverse direction. It starts out higher, but then goes lower as loneliness increases. Now, that could be a classic pattern in which, as you increase additional environmental stressor to the system, that there was not adequate resilience resources to deal with that increased load, so the estrogen crashed. And that could be one interpretation of this. This one looks like that the non-decompressed people did have the resilience resources to increase estrogen at a higher level if they had high levels of loneliness. Now, if we moved on to that and said, all right, so bad things happen to decompressed people in terms of estrogen and resilience, better things happen to non-decompressed, is there anything that we have to look at for decompressed people in terms of something interesting that we might be able to work on? And what we did, so I should note that the simple effect for estrogen at the two different surgery status conditions, it was significant for non-decompressed because that was a huge difference, and it was approaching significance at p equals 0.07 for the non-decompressed. The only real thing there that's important for this model is that there's a different pattern of results, in which there certainly was. So estrogen levels go up with loneliness for non-decompressed, they go down with loneliness for decompressed, or if you prefer, they remain stable. Now, what we could do is say, all right, we have three factors in this model: the environment, the HPA axis, arousal response, and the biological resilience response. What you might be able to do is see if differences in environmental stressors or how you deal with them could have an effect even on people that don't have adequate biological resilience to cope with the strain. So we were very interested in looking at whether the relationship between estrogen and different measures of trauma from the impact of event scale would be mediated by loneliness, because loneliness was our main environmental stressor. In particular, as loneliness went down, then even in decompressed people, you should have higher estrogen levels to deal with the trauma. And that's what we found. We found it both for avoidance and intrusions, where this was a mathematical mediation model in which, after we added loneliness into the model, so your last regression model uses both loneliness and intrusions to predict estrogen levels. So before, there was a significant correlation between intrusions and estrogen. When you add loneliness, it goes away. Same thing for avoidance. And that's how we test a mediation model and assume that loneliness causes that relationship. Now, I always get worried when people say it causes it. We're not sure if it causes it, but at some point it's related probably in something like a causal change. Critically, both of these included a Sobel test, so there is mathematical mediation going on in both of those models. So, where do we stand? we have initial support for a dynamic interplay model of symptomatic Chiari malformation if you're willing to accept our assumptions. One, you need pre-existing anatomical deformations. Two, you need environmental stressors. Three, you need individual differences in how people respond to the environmental stressors from the HPA axis on the arousal side, and furthermore on the resilience side that moderates the arousal. And we found evidence of all of that. One, Chiari patients show high levels of loneliness effects. We also found that interaction for different estrogen levels as a function of surgical status and loneliness group. And finally, even when we looked at decompressed people alone, we still showed that loneliness mediated the relationship between estrogen and trauma effects. So I think we have the initial evidence that maybe part of the reason why people become symptomatic has to do with this dynamic interplay between these variables.